I am Dr. Charles Faiman, the chair of the virtual Grand Rounds sessions on type 2 diabetes. I am a former chairman of the Department of Endocrinology, Diabetes, and Metabolism at the Cleveland Clinic and currently a consultant in the department. This is the fifth and concluding lecture in our third season of CME-approved case-based management presentations dealing with type 2 diabetes. As emphasized in previous presentations, type 2 diabetes has become a major health care issue in both this country and the world at large. The most recent estimate is that almost 26 million, or over 8% of Americans, have diabetes. It has been estimated that 1 out of 3 Americans born in the year 2000 will develop diabetes in their lifetime. Diabetes carries with it a dramatically increased cardiovascular disease risk. The healthcare burden for diabetes in America is enormous, estimated to approximate $200 billion annually at present. Today's topic of cardiovascular disease risk reduction in patients with type 2 diabetes is both timely and clinically relevant. It is my pleasure now to introduce Dr. Michael Rocco, who is the Medical Director of Cardiac Rehabilitation and Stress Testing at the Cleveland Clinic. Dr. Rocco is well recognized as an author and as a popular speaker at local, national, and international venues. Dr. Rocco.
In this session, we will review the strong link that exists between diabetes and cardiovascular disease adverse events and discuss both the rationale for and recommendations for non-pharmacologic and pharmacologic interventions to try to reduce cardiovascular risk. We'll also spend some time highlighting some more recent controversies in lipid management. I'd like to begin by presenting a patient example which I believe illustrates the issues that we want to discuss throughout the context of this talk, and refer back to this patient at the end to discuss appropriate therapeutic interventions. So Mr. Risk is a 56-year-old African-American who was recently diagnosed on routine follow-up with his primary care provider with type 2 diabetes and started on metformin 500 milligrams twice a day. He has a past history of hypertension, on amlodipine, a family history of diabetes, and admits to a sedentary lifestyle. He reports that recently he finds if he tries to briskly walk up a hill, he develops a mild cramp in his left calf. He denies any other previous cardiovascular symptoms or testing. He's a non-smoker and drinks alcohol only occasionally. So he's 5'9", 210 pounds with an elevated BMI in the obese range at 31, with waist circumference of 39, and blood pressure of 150/88, not well controlled on amlodipine. In terms of his cardiovascular specific examination, it is fairly unremarkable other than some mild reduction in the left ankle pulses and a soft left femoral bruit. So this slide demonstrates clinical data and laboratory data in the patient. His total cholesterol is elevated at 230. He has an LDL cholesterol of 141, low HDL of 38, and triglyceride of 256, and a non-HDL cholesterol, which is the total cholesterol minus HDL cholesterol, elevated at 192. Fasting glucose is 146, with a hemoglobin A1C of 4.2, with normal liver function studies and creatinine. Other laboratories, including the CBC, complete metabolic panel, and thyroid screen, are normal. No significant microalbuminuria was present in the urine. Due to his left leg complaints, an ankle brachial index, or ABI, was obtained, which was abnormal at 0.81 on the left and normal on the right. And his EKG did demonstrate evidence for left ventricular hypertrophy, but was otherwise within normal limits. So let's pause here and ask ourselves a question. Which of the following statements is not true regarding diabetes and cardiovascular disease? A, atherosclerosis accounts for approximately 65 to 75% of all diabetic mortality, with about three-quarters of these deaths due to coronary atherosclerosis. B, increases in cardiovascular fitness may be beneficial in reducing cardiovascular mortality in both normal weight populations, but also in overweight and obese populations. C, 60% of patients with newly diagnosed diabetes are overweight or obese. D, a 7% modest reduction in body weight can markedly improve insulin sensitivity by up to 60%. E, risk for atherosclerotic events in diabetics compared to non-diabetics is increased by 2 to 4-fold. And lastly, F, a diabetic patient's risk of cardiovascular mortality or having a myocardial infarction is equivalent to a non-diabetic who has already had a myocardial infarction. So which of these statements is not true? And with this question, as with other questions throughout the context of this discussion, the answers to the questions will be contained within the content of our talk today. So let's move on to the next slide, which exemplifies this concept of the diabetic as a coronary heart disease risk equivalent. This is a now famous slide from a study published in the New England Journal in 1998, looking at the 7-year incidence of myocardial infarction in diabetics and non-diabetics with and without a prior history of myocardial infarction. And as you can see in the middle two panels, that a diabetic patient who has never had a clinical myocardial infarction or event has a likelihood of developing his first myocardial infarction at the same rate or higher than a non-diabetic who has already had a first myocardial infarction, 20% versus 19%. Thus, this concept of diabetes as a coronary heart disease risk equivalent. And on the far right, you can see that a diabetic that has already had a myocardial infarction has an extremely high risk, over 45% or so, of developing a myocardial infarction over 7 years. So obviously, this represents a high-risk population for cardiovascular events. So let's review some facts relative to diabetes and cardiovascular risk. First, this concept of risk equivalent, as we've recently discussed, but also atherosclerosis-related events account for about 65 to 75% of diabetic mortality, and 75% of these events is due to complications of coronary atherosclerosis and myocardial infarction. Also, we know that atherosclerosis begins years to decades prior to the diagnosis of type 2 diabetes. And in fact, greater than half of patients that are newly diagnosed with diabetes have already had clinical manifestations of coronary heart disease or other vascular disease. On the flip side, when patients present with an acute coronary syndrome, over 30% are at that time newly diagnosed with diabetes, and another third are newly diagnosed with impaired glucose tolerance. So in patients that present with adverse events, the diagnosis of diabetes was not present prior. And diabetics that do present to the hospital and have a myocardial infarction or have revascularization procedures such as bypass surgery or percutaneous intervention have a higher complication rate and mortality than non-diabetic patients. So overall, the risk for a cardiovascular disease event in the diabetic is 2 to 4-fold higher than in non-diabetics. It's also important to point out that risk factors are very important in assessing cardiovascular risk in the diabetic population. In this study published about 10 years ago, or 20 years ago, 1993, in Diabetes Care, looking at 3 risk factors, elevated cholesterol, cigarette smoking, and hypertension, you can see that both in the diabetics in orange and the non-diabetics in blue, that there's a stepwise increase in age-adjusted cardiovascular death rate as we add together risk factors. But at any one of these categories, the diabetic, even those with no cardiovascular risk factors, the risk of cardiovascular death is higher. And in fact, if you look at the diabetic as highlighted with only one risk factor, the risk of cardiovascular death is as high or higher than the non-diabetic with all 3 of these risk factors. So just emphasizing the importance of identifying and treating risk factors in this patient population. Weight is also an important issue in diabetics, and in fact, if we look at some data from the National Health Interview Survey, this was published 10 years ago, that newly diagnosed diabetics, 90% of the time are either overweight, a BMI between 25 and 30 and 30%, or obese, a BMI greater than or equal to 30 and 60%. So weight management and issues are very prominent in the diabetic population. So what are our goals in the management of cardiovascular disease in this patient population? Well, as in most patients with cardiovascular or coronary disease, one approach is to try to improve symptomatic state to enhance quality of life, and also to identify the extent of myocardial ischemia in coronary patients, because it may influence decisions regarding revascularization. But by and large, the most important target for treatment to reduce cardiovascular events is to identify risk factors and intensely manage them, identify and treat hyperglycemia, and lifestyle interventions, including nutritional support, exercise recommendations, weight management, and smoking cessation. And it's really this first goal that we're going to spend most of our time discussing. So let's focus on weight loss. You can see in this slide that even modest reductions in weight, about a 5 to 10% reduction, can substantially reduce hemoglobin A1C and glycemic measurements, reduce blood pressure, improve lipid criteria, and improve insulin sensitivity. So let's look at this a little bit more specifically on the next slide. We know, for example, from the Framingham Heart Study, that a 5 to 10% reduction in weight can be associated with a 6 to 7% reduction in cholesterol and 4 to 5% reduction in blood pressure. Also, short-term weight reduction has been associated with improvement in endothelial function in obese individuals, as measured by flow-mediated dilatation in the forearm. And this is similar whether patients are normal glycemic, diabetic, or have impaired glucose tolerance. We also think of atherosclerosis, and particularly adverse events related to plaque instability, as an inflammatory process, and weight loss has been shown to reduce inflammatory cytokines and also increase beneficial adiponectin levels in individuals with diabetes and prediabetes. The Joslin Clinic has demonstrated that a modest 7% reduction in body mass index or weight is associated with a 57% improvement in insulin sensitivity. So I think the practical goal of a modest 7 to 10% weight reduction is achievable and does seem to go a long way. Well, let's turn our attention to exercise and some facts about exercise in the diabetic population. The IRIS study showed that there is a stepwise improvement of insulin sensitivity and reduction in fasting insulin with increases in the frequency of exercise. And ACLS has also shown a strong relationship to the level of fitness and cardiovascular disease mortality. So there does seem to be a dose-response effect with exercise. Also, the benefits of moderate intensity exercise have been shown in diabetics across all levels of BMI, in those that are of normal weight, overweight, and obese. So there's no reason to deny exercise based on BMI or body weight. And even modest exercise can be beneficial. For example, one study in diabetes patients demonstrated that just walking for 2 hours per week compared to sedentary diabetics reduced cardiovascular mortality by 34% and all-cause mortality by 39%. And even here there was a dose response, that those individuals that exercised for more than 4 hours per week had an even greater reduction in mortality. Increases in leisure activity can be as effective as structured exercise. Some people are adverse to gym and structure, but really focusing on increasing leisure activity can be beneficial. And it's also been shown that home programs can be just as effective as a structured exercise program and are often associated with better adherence. It's also important to remember that exercise is an important aid in weight loss and weight loss maintenance. Many of these patients may need higher exercise goals to achieve this, but it's also been shown that it is not always necessary to do long, intense sessions, that shorter, more frequent bouts of exercise throughout the day can achieve similar results with probably better adherence in the long run. So let's stop for another question. Therapeutic recommendations to aid in reduction of cardiovascular risk in diabetic patients includes all except the following. A, systolic blood pressure less than 140 and diastolic less than 80. B, low-dose aspirin 75 to 162 milligrams in all patients with diabetes. C, at least 150 minutes of moderate intensity aerobic activity a week, spread out over at least 3 days, but with no more than 2 consecutive days without exercise. D, in individuals that have overt cardiovascular disease symptomatically, an LDL cholesterol goal of less than 70 milligrams per deciliter is a reasonable option. And E, statins should be started to reduce cardiovascular risk, regardless of the LDL cholesterol levels, in diabetic patients with overt cardiovascular disease. So the management of these patients is a multifactorial approach, and it's important to remember that we need to attack multiple factors if we're going to substantially reduce cardiovascular risk in this patient population. Here is some general data from the Steno-2 trial looking at intensive therapy, where pharmacologic and non-pharmacologic treatments to achieve aggressive hemoglobin A1C goals of less than 6.5, cholesterol less than 175, and blood pressure less than 130/80 were compared to conventional therapy. And when intensive efforts were made to achieve these goals, there was a 53% reduction in composite of cardiovascular disease endpoints in the intensive treated group versus the conventional treatment group. So combination therapies directed toward multifaceted therapies can be very beneficial in reducing event rate. So beyond lifestyle interventions, which we've alluded to already, what is available and what is important in terms of pharmacologic interventions? So if we look at the risk factors of dyslipidemia, hypertension, hyperglycemia, and insulin resistance, and platelet aggregation and activation, a number of therapeutic approaches have been shown to be beneficial at reducing progression of atherosclerosis, and more importantly, stabilizing the atherosclerotic process so that atherosclerotic plaques are less prone to rupture and thrombosis and lead to acute adverse events. So let's start at the bottom and work up and look at some of these interventions. So what about antiplatelet therapy with aspirin? This is some data from the Antiplatelet Trialist collaboration. And as you can see, the diabetics on the left have an absolute higher risk of cardiovascular events, whether in the control group on treatment. But compared to the non-diabetics, there's a similar absolute event rate reduction when antiplatelet therapy, here predominantly with aspirin, was instituted in individuals with diabetes. So based on these observations and others, the ADA currently recommends low-dose aspirin 75 to 162 milligrams per day for all diabetics in a secondary prevention population, and to consider clopidogrel if aspirin intolerant or allergic. In primary prevention patients without overt cardiovascular disease, low-dose aspirin is recommended for all individuals with a greater than 10-year cardiovascular event rate estimated at greater than 10%. Now, one easy way to remember this is that any male over 50 or female over 60 with at least one additional risk factor will fall into this category, and this represents a large percentage of our primary prevention diabetics. However, since the risks of long-term exposure, particularly in young individuals, to aspirin and bleeding risk may outweigh the benefits in individuals that have a low 10-year risk of less than 5%, aspirin is not recommended universally in this primary prevention population. So aspirin for many patients, but not in all. Just a few words about glycemic control. Meta-analyses of pharmacologic treatment studies, particularly with metformin and type 2 diabetes, has found that at best, intensification of glycemic control is associated with only a modest reduction in macrovascular disease. And in fact, the ACCORD trial was stopped prematurely due to an excess mortality among diabetic patients in the more intensive glycemic group, where the A1C goal achieved was 6.4% compared to between 7 and 7.9%. And both the ADVANCED and VADT studies showed no benefit of tight control on cardiovascular disease endpoints. Now, the choice of medicines may be important as well. For example, in the PROACTIVE trial, treatment with pioglitazone was associated with a 28% reduction in myocardial infarction compared to those on placebo. And we also know that other therapies, such as rosiglitazone, and even some newer therapies now, have been associated potentially with increased cardiovascular risk. So aggressiveness of treatment and choice of therapy may be important in reducing macrovascular disease. So in general, however, lowering A1C to below or around 7 has been shown to reduce microvascular complications of diabetes and seems appropriate. And, at least in sub-analysis, and implemented soon after the diagnosis of diabetes, also tends to be associated with long-term reduction, but to a lesser degree, of macrovascular events. So a goal of less than 7 in most diabetics seems reasonable to try to achieve, as long as it can be done without complications or significant hypoglycemia. Now, this slide from a recent study just published in 2013 in the Journal of General Internal Medicine by Nichols demonstrates the importance of focusing on non-glycemic goals for therapy. In this Kaiser study, looking at over 26,000 patients followed for an average of 5.6 years, and looking at hospitalizations for cardiovascular disease, when A1C, blood pressure, and LDL cholesterol were looked at as univariate factors controlled for demographics, comorbidity, and meds, for every standard deviation in hemoglobin A1C, there was not much of an increased risk or difference in terms of CVD hospitalizations. However, for each standard deviation increase in systolic blood pressure and LDL cholesterol, there was a 40% increase likelihood of hospitalization for cardiovascular disease. And if we look at levels of control, A1C less than 7, systolic blood pressure under 130, and LDL less than 100, with those individuals with low hemoglobin A1Cs, if anything, the trend was toward an increase in hospitalization, whereas individuals with tighter control of blood pressure and LDL cholesterol had a 37 and 48%, respectively, reduction in hospitalization. And when we look at control of these factors alone or in combination, in individuals with diabetes with none of these goals achieved, their rate of hospitalization was 18.2 per 1,000 person years. With control of A1C only, this dropped only slightly to 16.9. But with either blood pressure or LDL below 130 and 100 respectively, hospitalization rate dropped to 9.6 and 11.6 in these two categories. And when both were controlled, the lowest hospitalization was seen at 6.1 per 1,000 person years. And this, in fact, was slightly lower than when all three, blood pressure, LDL, and hemoglobin A1C, were controlled. So this just emphasizes the importance of identifying and managing hypertension and hyperlipidemia in this patient population. So let's look first at hypertension. On the left, the systolic hypertension in Europe trial demonstrates that both in non-diabetic and diabetics, there is a reduction in cardiovascular event rate with treatment of systolic blood pressure. And in fact, this is much greater both in terms of relative risk reduction and absolute risk reduction in the diabetic population compared to non-diabetics. On the right, we're looking at diastolic hypertension control in the HOTS trial. And in non-diabetics, if you get your blood pressure diastolic under 90, there's not much difference in terms of event rate whether you work further to get it below 85 or 80. But in the diabetic population, with further incremental reduction of diastolic blood pressure to below 80, there is further reduction in cardiovascular event rate. In addition, the choice of medication may be important. This is looking at the results of the HOPE study, where ramipril was added on top of standard therapy in patients at high risk for cardiovascular disease and followed for 4.5 years. When we look at the composite endpoint of stroke, myocardial infarction, and cardiovascular mortality, both in the non-diabetic patients on the right and the diabetic subgroup on the left, there was a similar relative risk reduction in cardiovascular event rate. And in fact, in the diabetic populations over time, there was attenuation of development of microalbuminuria in the ACE inhibitor group versus the placebo group. So how does that reflect into our current recommendations for blood pressure management in the diabetic population? Well, first, we should always measure blood pressure at every routine follow-up visit, and if elevated, should bring them back and confirm on a separate day. People with diabetes and hypertension should be treated to a systolic blood pressure at least less than 140 milligrams of mercury, and lower systolic targets under 130 may be appropriate in individuals such as younger patients where we can achieve this goal without undue burden in terms of drug-drug interactions and complications, and in higher-risk patients such as patients with cardiomyopathy, prior myocardial infarction, or renal insufficiency. Diastolic blood pressure, based on what we saw in the HOTS trial, we should try to treat to less than 80 millimeters of mercury. If blood pressure is only mildly elevated, over 140 over 80, in addition to lifestyle intervention, we should consider prompt initiation of pharmacologic therapy to achieve blood pressure goal, and knowing that in the majority of these patients to achieve goals, we will often need to use combinations of therapies. And choice of medicine remains important. Whenever possible, unless contraindication, we should include either an ACE inhibitor or angiotensin II receptor blocker. If one class is not tolerated, consider using the other. So let's talk a little bit about hyperlipidemia. This is a multivariate analysis from the UK PDS study looking at development of new cases of coronary artery disease in follow-up in diabetic patients. In this multivariate model looking at standard risk factors for cardiovascular disease, the most important risk factors associated with the incidence of new coronary disease were lipid parameters, elevated low-density lipoprotein and low high-density lipoprotein. And these were stratified in the model before measures of glycemic control, blood pressure, and presence or absence of cigarette smoking. And a retrospective analysis that had been performed on the Steno-2 trial, which we talked about briefly earlier, suggested that up to 70% of the benefit that was seen in risk reduction in the aggressively treated group of patients was explainable by management of LDL cholesterol. So identification and treatment of LDL cholesterol remains important. And let's stop and ask another question regarding dyslipidemia management in patients such as Mr. Risk. In our patient, all of the following are true except A, statins are the first-line therapy for management of dyslipidemia. B, non-HDL cholesterol, total minus HDL cholesterol, and apolipoprotein B measurements are better predictors of future cardiovascular events compared with LDL cholesterol, and therefore are secondary targets for therapy. C, even in individuals treated aggressively with statins to low LDL levels, low HDL cholesterol remains associated with a higher risk of adverse cardiovascular events. D, clinical trials have shown that the addition of fibrates or niacin to aggressively treated statin patients is associated with a significant and incremental reduction in cardiovascular risk. And lastly, E, NHANES data indicate that although goals such as an A1C less than 7, systolic blood pressure less than 130, and LDL cholesterol less than 100 have been recommended for patients with diabetes, only about 19% of diabetics in the survey achieved all three of these goals. Well, let's get back to some comments about lipid management. The CARDS trial was a primary prevention trial in patients with diabetes with one or more cardiovascular risk factors but no known cardiovascular disease. The average LDL cholesterol at the entry to the study was only 117 milligrams per deciliter. These individuals were randomized to atorvastatin, 10 milligrams versus placebo, and the study was stopped prematurely because of a 37% reduction in event rate in the treatment group versus the placebo group at interim analysis. Also seen was a 48% reduction in stroke and 47% reduction in non-fatal myocardial infarction. So the message is, in diabetes, even without cardiovascular disease, with one or more risk factors, that even modest LDL cholesterol is associated with high risk, and early treatment can substantially reduce cardiovascular risk. On this next slide, if we look at a number of diabetic subgroup analyses and other clinical trials, we can see similar effects. In the ASCOT lipid-lowering arm, looking at diabetics with hypertension and risk factors, as well as in the heart protection study, looking at all the diabetics versus those with diabetes and no cardiovascular disease, when statins were compared to placebo, there was anywhere from a 23 to 37% reduction in cardiovascular event rate. And in the TNT trial, treating to new targets, where a strategy of aggressive treatment versus less aggressive statin therapy was used, 80 milligrams of atorvastatin versus 10 in a secondary prevention population. In the diabetic subgroup, there was a 25% further reduction in cardiovascular event rate when more aggressive statin therapy was utilized, and this was similar to in the general population. So I think that the message from these studies are as follows: that statins remain the primary treatment for cardiovascular disease reduction in dyslipidemic patients, whether primary or secondary populations of cardiovascular disease. Secondly, therapy should be initiated even for modest elevations in LDL cholesterol, particularly if one or more cardiovascular risk factors are present. And lastly, treating with more aggressive LDL cholesterol lowering, either higher doses or more potent statins, does offer incremental benefit in terms of cardiovascular risk reduction compared to lower or modest therapeutic interventions with statins. Now, while statins then are the mainstay of treatment, recently some concern has been raised that statins themselves may increase the risk of developing diabetes. And this first came to attention in 2009 when authors noted that in the West of Scotland trial, there was an increase in diabetes incidence reported in follow-up. In a meta-analysis of 6 trials in over 57,000 patients, including West of Scotland, there was about a 0.5% absolute increased risk of diabetes development. Now, they did another analysis excluding the West of Scotland trial, since this was defined as the hypothesis-generating trial. And when the other trials were looked at without West of Scotland, there was an attenuated 6% increased risk of diabetes development, but this was non-significant. More attention was received when in 2010, a Lancet article looking at a meta-analysis of 91,000 patients in 13 placebo-controlled statin trials reported development of new diabetes of approximately 4,300 cases during follow-up, and about a 0.4% absolute increased risk in patients on statins versus placebo, about 4.9 versus 4.5%, this equating to a 9% relative increased risk of incident diabetes, or one additional case of diabetes per 1,000 patient years of follow-up. Furthermore, a subsequent study a year later in JAMA was a meta-analysis of 5 trials in almost 33,000 patients comparing strategies of high-dose statins versus low to moderate dose statins. Again, was seen a 0.4 absolute percent increase risk of new diabetes in the more aggressively treated group versus the moderately treated group, or 2 additional cases per 1,000 patient years. But what does this mean in terms of management of patients? Well, I think the overall feeling is that the small risk of new diabetes outweighs the beneficial reduction in cardiovascular event rates. In the SATRA trial, looking at the cholesterol treatment trialist population of non-diabetics, they found approximately 5.4 less cardiac events for every 255 patients treated over a 4-year follow-up for each 1 millimole per liter or 40 milligrams per deciliter reduction in LDL cholesterol. This compared to 1 extra case of new diabetes for a similar number of patients over a similar follow-up. So about a 5-fold benefit in cardiovascular risk reduction versus new diabetes cases. In the meta-analysis of high versus moderate dose, they found 1 additional case of diabetes for approximately every 500 patients treated over 1 year, but it only took 155 patients treated over 1 year to reduce a cardiovascular event rate by 1, or about a 3-fold difference. And the increase in blood glucose that is noted in these clinical trials on statin therapy doesn't necessarily reduce the benefits of cardiovascular risk reduction. So Waters et al. Looked at 3 high-dose trials of atorvastatin with 80 milligrams and found that the cardiovascular event rate with non-new diabetics versus new diabetics in follow-up was similar, about 11.3 versus 10.8%. And in fact, even those patients that developed new diabetes had a significantly lower incidence of cardiovascular event rates, 10.1% versus 17.5% in individuals that entered the study already with index diabetes. And the reduction in cardiovascular risk was maintained across all groups. In addition, newer analyses have now demonstrated that those patients most likely to develop new diabetes on statins are those that are already at risk for diabetes, so individuals with abdominal obesity or other metabolic parameters. So what are the clinical implications? There does exist a strong relationship between diabetes and cardiovascular disease morbidity and mortality, and strategies to reduce the risk of adverse events remain of paramount importance. Aggressive multifactorial control of risk factors, particularly lipid management with statin therapy, has been shown to substantially reduce adverse cardiovascular events in moderate to high-risk populations, including those with diabetes. And so in these populations, statins should not be denied or doses reduced due to concerns about a modest increase in new-onset diabetes. However, it's reasonable with continuation of statins to monitor glucose more closely and emphasize the importance of weight reduction, diet, aerobic fitness for prevention of diabetes, since those patients on statins most likely to develop new diabetes are those that are already at risk. Next, I'd like to turn some attention to discussing treatment beyond LDL cholesterol, because there has been some newer studies and controversies raised regarding other therapies and their benefits in long-term reduction. The rationale for treating beyond LDL cholesterol is based on observations that even in individuals well-treated, events still occur, and this is true even after aggressive LDL lowering with statins. That's specifically in the diabetic population. In clinical trials, cardiovascular disease event rates have remained higher than the event rates in those patients without diabetes, even on placebo. So this high-risk group may benefit from more aggressive therapies. IVUS or intravascular ultrasound studies have shown that generally you need to achieve low LDL cholesterols below 70 to 80 milligrams per deciliter to see associated plaque stability or regression. But even in this subgroup, about 20% still progress, and that's often associated with the presence of diabetes, less increase in HDL, and less reduction in ApoB measurements on therapy. And progression of plaque in diabetes seems to be more strongly related to triglyceride and HDL ratio than even LDL cholesterol. We also note that there's an important impact of other atherogenic particles, such as low or abnormally functioning HDL, VLD remnants, elevated triglycerides, and small, dense LDL cholesterol, so therapies targeted toward these may potentially be of benefit. Non-HDL cholesterol, apolipoprotein B measurements, LDL cholesterol particle number, as well as ApoB, ApoA ratios have also been shown to be better predictors of long-term risk than LDL cholesterol content alone, particularly when examining on-therapy patients. So non-HDL cholesterol has been offered as an important secondary target for therapy, and to achieve these goals often requires combinations of therapies along with statins. However, positive results from long-term clinical outcome trials are still lacking. So why is this important? And that's exemplified on this next slide, looking at the TNT study. In this clinical trial, they pulled out all patients that achieved aggressive LDL lowering, less than 70 milligrams per deciliter on statin therapy, and stratified them according to quintile of HDL cholesterol. As you can see, even in these aggressively treated patients on statins, as HDL cholesterols dropped below 42, there was a significant increase in risk. So this raised the possibility that therapies targeted at raising HDL cholesterol, even on top of statin therapy, may offer incremental benefit in risk reduction. Now, fibrate studies have been available for a number of years. There are many monotherapy fibrate studies, such as the Helsinki Heart Study with gemfibrozol, the BIP trial with diazofibrate, field study in diabetics with fenofibrate, and the VA HIT trial with gemfibrozol. There are sort of mixed outcomes in terms of benefit in cardiovascular risk reduction across these monotherapy trials, some showing significant benefits, others not. But when sub-analyses were done and stratified patients into a metabolic pattern of dyslipidemia or patients with diabetes or metabolic syndrome, there was a much more significant and consistent reduction in cardiovascular events, suggesting that in the metabolic pattern patients, these therapies as monotherapy offered some benefit. But the important question remains, does adding therapies such as fibrates to statin therapies further reduce risk? And the ACCORD trial was the one trial looking at this in a placebo-controlled fashion, where individuals on a background of statin therapy with simvastatin were randomized to fenofibrate versus placebo. And in this group of diabetics, there was an 8% but non-significant reduction in cardiovascular event rates. However, in a pre-specified analysis, patients that fell into the highest tertile of triglycerides and lowest tertile of HDL cholesterol did trend to borderline significant reduction by 30% in event rate. So suggests that potentially in patients on statins that still have a metabolic pattern with high triglycerides and low HDL may benefit from combinations of therapy with fibrates, but this was not of statistical significance. Likewise, with niacin, studies have suggested that adding a niacin product to statin therapy may offer benefit. In the Arbiter trials, carotid intimomedial thickening was used as a surrogate marker for cardiovascular events. And Arbiter 3, which was a 24-month extension trial, compared statin therapy alone to statins plus extended-release niacin at 1 year and 2 years. And as you can see, the combination therapy was associated with a reduction in carotid IMT size by millimeters, and this was more prominent in individuals that had a clinical syndrome of diabetes or metabolic syndrome, suggesting that adding this therapy to statins may have important long-term events. However, there are few long-term clinical trials that demonstrate this. This next slide just looks at some niacin trials, some alone or in combination compared to placebo, which many of these trials were not designed to look at clinical events, but clinical outcomes were examined. The HATS class and the Arbiter 6 trial did demonstrate a trend toward reduction in cardiovascular event rates, although the sample sizes are small and most of these did not reach statistical significance. Both the Stockholm trial, which looked at niacin plus clofibrate versus usual care, and the Coronary Drug Project, which looked at niacin versus placebo, were designed to look at clinical outcomes. And at least looking at niacin in this pre-statin era in secondary prevention populations, there was a 20 to 40% reduction in clinical outcomes. A recent meta-analysis looked at a number of these trials and myocardial infarction events, and this was shown to be reduced by approximately 25%. However, as mentioned, most of these trials really did not address the important question: what happens from a clinical outcome standpoint when we add niacin therapy to aggressive statin therapy? So there have been some clinical trials, some recently published, looking at this question. We alluded to the Accord trial with fenofibrate added to statins, which in the general population did not show benefit in the primary endpoint. The AIM-HIGH trial, comparing niacin plus simvastatin to simvastatin alone, plus or minus ezetimibe, was stopped early, an interim analysis due to futility. And the heart protection study, THRIVE study, looked at niacin added to a background of simvastatin in over 20,000 patients, was recently presented at the 2013 American College of Cardiology. This study, with over 4 years of follow-up, showed no difference in the primary endpoint when niacin was added to simvastatin. I think it's important to recognize that in both the AIM-HIGH trial and the heart protection studies, that patients entered the study with very aggressively treated LDL cholesterol, somewhere between 60 and 70 milligrams per deciliter. So I think the message here is in subgroups of individuals on statins with aggressively treated LDLs to less than 70 milligrams per deciliter, in these two trials, it does not appear to be incremental benefit by adding niacin. Now, there are other trials in progress to look at CETP inhibitors or cholesterol ester transfer protein inhibitors. These are drugs that can raise HDL cholesterol anywhere from 30 to 140%. The Illuminate trial with torcetrapib was stopped prematurely due to adverse events in the group on treatment, which was attributed to off-target effects of the drug in terms of its effect on the angiotensin-aldosterone system and increase in blood pressure. Now, dalcetrapib in DALE Outcomes trial had a modest effect on HDL, raising it approximately 30%, but did not have the same off-target effects seen with torcetrapib. However, this study was stopped at an interim analysis recently because of futility. There are two more potent CETP inhibitors, anacetrapib and evacetrapib, which raise HDL cholesterol well over 100%, but also have substantial effects on further reducing LDL cholesterol. These two clinical trials are ongoing, and the answers are not yet in. So where are we now in terms of HDL, cholesterol, and triglyceride management? Well, there is a clear association with low HDL cholesterol and high triglycerides in adverse events, and this seems to be present even on subgroups of patients treated aggressively with statins. However, data from long-term outcome studies demonstrating incremental benefit when added to well-treated statin patients are lacking. Aggressive treatment of lipid abnormalities then with statins remain the primary target in high-risk patients, even those with low HDL cholesterol. Aggressive reduction of atherogenic ApoB-containing particles, which may be measured by non-HDL cholesterol, direct ApoB measurements, and or LDL particle numbers, are reasonable secondary goals in management of patients that are on statins and in maximal doses. And although the clinical trials suggest that routine addition of niacin and fibrates to statins may not offer incremental benefit, there may still be a role for the use of these therapies in patients that have primarily elevated triglycerides, particularly triglycerides above 500, those individuals that have elevated non-HDL cholesterol or ApoB measurements after maximally tolerated statin therapy has been applied, and also in patients that are on maximally tolerated statins but still have primary goal of LDL above treatment standards. In fact, it's important to remember that niacin, for example, while it may raise HDL cholesterol 20%, at maximal doses can also lower LDL cholesterol 15 to 20%. And it's very important to continue to remember that in our patients with high non-HDL cholesterol, low HDL, and triglycerides, lifestyle interventions remain very important. Weight reduction, diet, cessation of cigarette smoking can go a long way at helping to treat these mixed dyslipidemias. So one question about treatment then in our patient. Based on the current guidelines, lipid goals for the management of our patient are A, LDL less than 70, non-HDL less than 100, and or ApoB less than 80, B, less than 100, 130, and 90, respectively, for the same parameters, C, LDL less than 70, non-HDL less than 130, and ApoB less than 90, and D, lastly, less than 130, 160, and less than 100, respectively, for the same parameters. Which of these would be the appropriate treatment goal in Mr. Risk? Having chosen that goal, then, what would be the best initial treatment for Mr. Risk's dyslipidemia? Atorvastatin, 80 milligrams a day, pravastatin 40 plus fenofibrate due to the elevated triglycerides, extended-release niacin plus a resin, simvastatin, 20 milligrams plus ezetimibe, or rosuvastatin, 20 milligrams plus high-dose omega-3 fish oil. Which would be the best initial treatment? So this slide responds to the previous question based on recommendations from the ADA-ACC consensus statements for diabetics or patients with cardiometabolic risk. In all patients with cardiovascular disease or diabetics with one or more additional cardiovascular risk factor, an LDL less than 70, non-HDL less than 100, and ApoB less than 180 are appropriate therapeutic goals. In all other diabetics without cardiovascular disease or non-diabetics with two or more cardiovascular risk factors or no known CVD, goals of less than 100, less than 130, and less than 90 are appropriate. In addition, statin should be added to lifestyle therapy regardless of baseline lipid levels when overt CVD is present or without CVD in individuals over 40 years of age with one or more risk factors. And combination therapies with fibrates or niacin added to statins may be necessary to achieve secondary lipid targets, but it's important to remember that this has not been shown to be associated with additional outcome benefit when added to aggressive statin therapy in available clinical trials. So in summary, then, goals for treatment are as follows. For lifestyle modification, Class 1 indications include smoking cessation, physical activity characterized by 150 minutes of moderate intensity activity, meaning at 50 to 70% of maximal heart rate each week, and consider resistance training at least 2 times a week if not contraindicated. Adequate weight management and waist circumference management, and dietary intervention to promote weight loss, reduce alcohol and sodium consumption with an emphasis on fruit, vegetables, low saturated fat, and dairy. In terms of other targets, specifically for therapy, for glycemic control, tighter control as possible to achieve normal A1Cs without inducing hypoglycemia, with a reasonable A1C target of less than 7%, blood pressure target of at least less than 140 systolic, and in some subgroups less than 130, with diastolics less than 80, with early institution of pharmacologic therapy, with ACE inhibitors or ARBs being part of the blood pressure lowering regimen whenever possible. In terms of lipid management, a goal of less than 100 milligrams per deciliter in all of these patients, but a reasonable goal of less than 70 in a large percentage of the highest risk groups. Statin should be started for cardiovascular disease history or anyone with diabetes and age over 40 with one or more risk factors, regardless of the baseline LDL cholesterol, to lower LDL by 30 to 40%. And if the LDL is greater than 100 with other risk factors, statin therapy should be started. Aspirin should be used in all patients with cardiovascular disease or a cardiovascular risk of greater than 10% per year, but not necessarily in low-risk primary prevention diabetes. And ACE inhibitors or ARBs should be considered in individuals with known cardiovascular disease, particularly with prior myocardial infarction or cardiomyopathy with LV dysfunction, or individuals over 40 years of age with one or more cardiovascular risk factors. So how well are we doing? Well, if we look at NHANES data between 1988 and 2010, and we look at goals for therapy of an A1C less than 7, blood pressure less than 130 over 80, or LDL less than 100, you can see that we've certainly made progress over these 4 strata of analysis, with some of the biggest gains being seen in utilization of statins to achieve LDL goal. But for each of these individual goals, we're not achieving much more than 50% goal achievement. And we look at all 3 of these goals together. Even in the most recent analysis, only about 19% of diabetic patients are treated to achieve all 3 of these goals. Now, just one brief comment about additional testing, particular stress testing for evaluation of coronary artery disease in diabetics. Why is this important? Well, the prevalence of coronary disease, as we indicated, is high in diabetes and may often be underestimated by symptoms. But the important question to ask is, does documenting ischemia and referral for revascularization alter these outcomes? And would early identification of preclinical or asymptomatic coronary disease change or intensify therapy? Well, I think the bottom line is that since we should already be aggressively treating risk factors in these patients, the role of testing for coronary ischemia is not necessarily to document the presence of coronary disease in order to make risk factor treatment decisions, but to identify those that have more extensive disease or a high-risk anatomy in whom further testing might lead to institution of other treatment options. Now this, for example, assumes that identifying large ischemic burden will influence decisions for therapies such as revascularization. And this certainly may be true in diabetes with symptoms and documented multivessel disease, where they appear to do better clinically and in terms of mortality with coronary artery bypass grafting rather than interventional therapies percutaneously or medical therapies. However, in low-risk asymptomatic patients, documenting ischemia routinely on testing has found not to be very common, and in the DIET trial did not seem to have any discernible overall effect on subsequent cardiac events. So in low-risk patients, routine testing may not alter our treatment choices. Patients that may also benefit from screening are those in whom the exercise recommendations may be modified based on the results of tests, or patients that are fairly sedentary and want to start an exercise program. So this next slide, I think, is a reasonable algorithm for making choices regarding stress testing in patients with diabetes. In those patients that are symptomatic, with chest pain, but also potential risk equivalents such as exertional dyspnea, or have other clinically evident cardiovascular disease such as carotid disease or peripheral arterial disease, stress imaging is appropriate with either perfusion or wall motion abnormalities by nuclear echo testing. And in those individuals that have moderate to severe perfusion or wall motion abnormalities, there is a role for coronary angiography to try to identify patients with left main or multivessel disease that might benefit from revascularization strategies. In those patients with symptoms that have no perfusion or wall motion abnormalities or mild ones, aggressive risk factor modification and medical therapy is the most appropriate, and consider repeat stress testing at 2 years. In the asymptomatic group, if they fall into a high-risk group, meaning a Framingham risk score where they have approximately a 20% 10-year risk of a hard cardiovascular endpoint such as infarction or death, or individuals that have had coronary calcification scores obtained that are elevated, moving on to stress imaging testing is appropriate and follow the same algorithm course for the symptomatic patients. In the majority of asymptomatic patients that fall into a low-risk or intermediate-risk group, if the individual is sedentary, over 35, and plans to begin an exercise program, and they have a normal baseline EKG, screening with an exercise electrocardiogram is appropriate to exclude latent coronary disease and ischemia, but also to help guide exercise recommendations. If that test is positive in the absence of symptoms, then moving on to stress imaging to rule out a false positive EKG response is appropriate. In low-risk patients with a normal exercise test, the main goal is risk factor modification and conventional follow-up in these patient populations. So CVD management in a diabetic patient requires a multifaceted approach with a broad-based treatment plan for management of dyslipidemia and hypertension primarily, and secondarily hyperglycemia in terms of its prevention benefits for cardiovascular disease. Aggressive risk factor screening and treatment remains the standard of care. There should be an emphasis, although difficult often to maintain in patients, on nutrition, maintenance of physical activity, weight management, and smoking cessation. Because diabetics are coronary heart disease risk equivalents, we should manage blood pressure and lipids aggressively as we would in secondary prevention populations of patients without diabetes, with aggressive LDL goals and primarily the use of statins for treatment. Non-HDL management is a secondary endpoint. There may still be a role for the use of niacin and fibrates in this subset of populations that have had optimal statin therapy but still remain above treatment goals, even in the absence of long-term clinical trials. Aggressive blood pressure lowering to at least less than 140/80, tight but judicious glycemic control to avoid hypoglycemia, and the use of medications specifically that have been proven to improve outcomes, such as beta blockers post-myocardial infarction and in cardiomyopathy patients, ACE inhibitors or ARBs in ACE-intolerant patients, aspirin therapy in the majority of diabetics, but not all, and statin therapy. Stress testing and functional imaging does have a role in the symptom evaluation and in assessment of high-risk asymptomatic patients, primarily to assess for the extent of ischemia and potential suitability for revascularization. But stress imaging in asymptomatic patients or those with preclinical disease has a selective role, and universal stress imaging studies and screening is not practical or recommended. But sometimes stress testing may be important in patient encouragement to pursue aggressive risk factor management and get started in exercise programs. So finally, returning to Mr. Risk, his management does need to be multifaceted. We should institute lifestyle changes with the goal of 30 minutes of moderate intensity aerobic exercise at least 5 times a week. And we often will refer our patients for formal exercise prescriptions. This gives us an opportunity to make sure the patient is exercising at an appropriate level for his needs, and also can offer ongoing reinforcement of exercise goals with return appointments. Nutrition consultation is very important in the management of these patients and should try to be used whenever possible. He was started on low-dose aspirin therapy, 81 milligrams a day, being a high-risk diabetic patient with multiple risk factors and peripheral arterial disease. An ACE inhibitor, or ARB, should be added, specifically since he is above treatment goal. Statin therapy should be instituted as a primary therapy with an LDL goal of less than 70 and non-HDL goal as a secondary target of less than 100. Reasonable to continue his metformin. And because of his history of peripheral arterial disease, sedentary lifestyle, and plans to begin an exercise program, screening stress imaging is appropriate. He was able to exercise to 8 METs, indicating that his peripheral arterial disease was not a major limiting factor in terms of exercise, and achieved 86% maximal heart rate without chest pain, diagnostic EKG changes, or echo wall motion abnormalities to suggest ischemia. So aggressive medical therapy remains an appropriate plan in this patient. So we elected to put the patient on 80 milligrams of atorvastatin as our first choice, since we are trying to achieve for our primary goal approximate 50% reduction in LDL cholesterol. He was started on aspirin 81 milligrams a day and had ramipril 10 milligrams a day added to his amlodipine and was continued on metformin. At 4 months, his LDL cholesterol had dropped to 78, so still above a goal of 70, but much improved. Small increase in HDL cholesterol, which can be seen with statin therapy. Modest drop in triglycerides, but still far above our treatment goal, and non-HDL cholesterol still above a goal of less than 100. Hemoglobin A1C dropped slightly. Liver function studies and creatinine remained stable. He lost approximately 5% of his body weight, and blood pressure was improved on the combination therapy. He has instituted an exercise program based on guidelines from an exercise prescription. So what do we do next in this patient? Well, we've already maximized to the highest dose of a potent statin, and we've not achieved goals. He's on appropriate medication choices for secondary prevention. His lipids still remain above goal, and we'd like to see a greater reduction in weight, at least a 10% reduction in weight to help improve metabolic parameters. So the plan was to further emphasize continued exercise and continue to work on weight reduction. We elected to add niacin to his medical regimen. And again, there's not a lot of long-term outcome data that suggests that this adds incrementally to the maximal atorvastatin dose, or that this is a better choice than considering addition of a fenofibrate or other LDL-lowering drugs such as ezetimibe. But with LDL cholesterol close to goal and triglycerides and non-HDL still above treatment goals, niacin is not an unreasonable choice as long as we understand that there are potential side effects we need to watch for and potential worsening in glycemic control with niacin. So he was placed on 1,000 milligrams of extended-release niacin, and 4 months later, LDL was down slightly to 72. We see a modest effect on LDL cholesterol at 1,000 milligram dose of niacin, but triglycerides have dropped further, as well as non-HDL. Still not at goal, but very close to treatment goals. Slight increase in A1C, liver function studies remain normal, but falling short on weight reduction. So we've gotten very close to achieving goals in this patient. He is on a reasonable combination of therapies for secondary prevention, some that have been added without long-term clinical trials, but at least some rationale for use. We're not done with this patient, though, however. Management of patients like Mr. Risk become a long-term enterprise. We need to watch very closely and constantly reinforce lifestyle interventions and appropriate use of medications and careful follow-up for side effects. Well, I thank you for your attention, and I hope that this program will be helpful for you in managing your many patients with diabetes and cardiovascular risk factors. Thank you.
Thank you so much, Dr. Rocco, for that informative review of cardiovascular risk factor reduction in a type 2 patient with the risk factors of obesity, dyslipidemia, hypertension, and peripheral vascular disease. Clearly, lifestyle modification is critical. Most importantly, a vigorous attack on lipids, blood pressure, and glucose, smoking cessation, and the addition of aspirin reaps major dividends in helping to reduce both morbidity and mortality. Permit me to add my personal reflections to Dr. Rocco's excellent presentation. I believe that the recent concerns expressed regarding the finding of an apparent increased risk of the development of diabetes in statin users will not stand the test of time. Even if it were true, the cardiovascular protection provided by statins will strongly trump this potential problem. I wish to point out two useful websites which the interested clinician should find extremely helpful. The first site is the United Kingdom Prospective Diabetes Study, the UKPDS, Risk Engine, to help in patient assessment. It takes into consideration the following variables: current age, gender, ethnicity, smoking history, presence of atrial fibrillation, as well as current data including systolic blood pressure, hemoglobin A1C, and total and HDL cholesterol. The Risk Engine provides risk prediction estimates for coronary heart disease and stroke in individuals with type 2 diabetes who are not known to have heart disease at entry. This tool, available for public use online, may prove to be of benefit not only in discussing therapeutic targets with patients, but also in helping to provide ongoing motivational incentives. Hopefully, it will help to promote patient adherence prior to the development of disease complications. The second website worth noting is the newly created one provided by the American Association of Clinical Endocrinologists called the AACE Diabetes Resource Center. It presents a comprehensive overview and management principles of both type 1 and type 2 patients, as well as of diabetes in pregnancy. In closing, on behalf of myself, Dr. Rocco, and the Cleveland Clinic, I thank you for attending this final session in our current series of virtual grand rounds.